but we need to talk about how will this be given in quality. A few statistics to start the session. 5 million people were shown to lose their lives, not because of receiving care, but because of the quality of care that they received. Quality care also needs to center on the patient, and technology is a key factor in ensuring quality of care. So to start us off in an energetic morning, we'll have TED Tiles talk sessions, and this is to inspire us to think about quality so that we're not just starting with a panel. So to start us off with our TED sessions, we have Dr. Steve Mutwiwa. Dr. Steve Mutwiwa is the country director of JAPIGO. He's a physician with over 18 years of service delivery and advocacy, managing and implementing large-scale integrated health projects in resource-limited settings with a focus on innovative, effective, and low-cost healthcare solutions. So Dr. Mutwiwa, thank you and welcome.
I'll need to move my slides. If someone can help me with a clicker. Or someone can just load the slide. Or can I just continue without it? All right, move to the next slide. Exactly. Well, I'm not sure that's the message I want to pass, but if you look at this, as I wait for a roaming mic, because I like moving around, especially for a TED Talk. Just to be, oh sure, yeah, excellent. So what you're seeing there, design is important. And why is it important? Because everything is designed with purpose in mind. And today, this morning, I want to invite you as we look at, is the design of the health system as it is today fit for the purpose of delivering health as we define it, or as we know it? The definition of health by WHO is the state of complete physical, social, and psychological well-being, and not just the absence of inequity or injury. So as the health system is designed today, I want to put across to you that it seems to be stronger, not in generating health as a commodity or promoting it, but it seems to be stronger in addressing the absence of health. It seems to kick in when you are losing your health, or when there is a threat to lose your health. I want you to reflect in your life, the last 12 months, how many hours did you spend with your doctor in the last 12 months? And how many of those hours did you spend with your doctor because either you or your doctor requested for those contact hours, not because you were losing your health or there was a threat to lose your health, but you just wanted to discuss the generation of health or the promotion of health? Don't answer me how many hours there were those. But I also want you to reflect, those 12 months, how many hours did you spend sitting? The kind of sitting that actually affected the way your health and your systems function. How many kilos of food did you take that actually affected your health status and the functioning of your health? Wouldn't it be so wonderful if the health system was designed in a way that it can walk the journey with you as you make decisions of how long you sit, what you eat, who you socialize with, and how you do that? If you had that kind of a system, we wouldn't get this situation. We have this friend of mine, he seems to be hungry. There is food there, but he doesn't seem to be interested in that food. Today we have a health system that don't quite reflect the situation that we have in Africa. You know, in Africa, when I visit you and you want to prepare a very nice meal, you put it on the table, and then you sit on the table and you're looking aside and trying to encourage me to enjoy that meal. What will happen? But today we have custodians of health, managers of health, who actually don't. If you don't increase the number of steps in the next 2 or 3 weeks, the functioning of your heart will reduce by maybe 3% or 5%. And together with it, the next time you are renewing your health premium, it will go up by 10%. Wouldn't that affect the way you behave and your health? I want you also to imagine the nappies that we wrap our babies, the blankets they sleep on. Do you know in the morning there is a way they can actually tell you what was the average temperature of that baby? And by extension, all the babies in our catchment area. It is also possible that that information can be relayed to the health provider and the health managers. It can also be relayed to a community dashboard where the community can meet and look at the status of their health. And when they look at it, they can decide. And I want to dramatize in this sense where you have the screen there, the community, and it tells you, since the health provider or the health manager that you appointed 2 years ago, your health status as a community has gone down by 10%. Can you click 1 if you want to continue with this health manager, or click 2 if you want to change that health manager? My point today, you can imagine of a transport system that only kicks in when cars roll and they need to get them back on the road. When the security system that kicks in when there is breach of security, how would life look like? But we train health providers that are not so skilled in promoting and generating health, but they are very skilled in diagnosing the absence of that health. We have a health information system that gives us more information about the absence of health, but not the generation and the promotion of health. We need to rethink the system. And I want to leave you with this quote by Henry Ford that says, whether you think you can or you think you can't, you are right. Ladies and gentlemen, I think we can change the way things are. Thank you very much.
Thank you very much, Dr. Mutwiwa. I will certainly be buying those shoes once they're out, and hopefully they'll keep me healthy. Thank you for starting the morning on an inspiring note, and we'll move on to our next TED speaker. Our next TED Talk speaker is Dr. Charles Ackerman. He is a co-founder of Mobicure, a social enterprise providing mobile technology solutions in healthcare for Nigeria and other developing nations. Mobicure provides patients with accurate, unbiased, and patient-friendly information and access for health professionals, with a focus on meeting patients' sexual and reproductive health needs, as well as maternal and child health. Welcome to the stage. We hope for inspiration.
Good morning, everyone. So just once again, I have some slides, so if you can be queued, please. How are we all doing today? Are we good? All right. So can we do this, or you want me to just... Excellent. So thank you once again for having me here. So the quest to achieving universal health coverage is one that many low and middle income countries, especially in Africa, are still struggling to accomplish. And millions of lives have been lost each year as a result. Now these deaths as a result of failure to achieve universal health coverage can really mainly be attributed to two main causes. Now, the first is poor quality healthcare, and the second is lack of access to healthcare. So there was a recent study last year by the Lancet Global Health Commission, which actually found that 5 million yearly deaths occur in low and middle income countries as a result of poor quality healthcare. 5 million. Also, 3.6 million yearly deaths are the result of lack of access to quality healthcare. Just think about that for a moment. That's 8.6 million deaths yearly. Now, coming closer to home, now I'm from Nigeria, and we fondly dub Nigeria as the giant of Africa. While we may be the giant of Africa, we are a classic example of a country that is grappling with trying to achieve universal health coverage. And this has really been represented in our maternal and child health, as well as sexual and reproductive health indices. Now in Nigeria, according to UNICEF, 2,300 children under the age of 5 years die every single day. Now that's a fact. Now also in Nigeria, abortion is criminalized. But according to a study by the Goldmarker Institute, there are 1.25 million induced abortions in Nigeria every year. And the result is that 34,000 young Nigerian women and girls die yearly from unsafe abortions. Now, if you add this to the fact that the doctor-patient ratio in Nigeria is 1 doctor to 5,100 patients, that gives you a very chaotic situation. But I'm not really here to talk about problems, because we know the problems and I can talk about it all day. I'm here to talk about solutions. Now, in the same Nigeria that we have these appalling, maternal and child health indices and appalling sexual and reproductive health indices, Nigeria is also a country where a high value is placed on communication. Now, according to our National Communications Commission, Nigeria has 168 million active mobile phone lines, which is the 7th highest in all the world. Think about that for a second. 168 million active phone lines. Also in Nigeria, we have 103 million internet users. So what does this tell you? This shows that there is a clear opportunity for mobile technology and innovation to be used to drive advance universal health coverage. And that's why I come in. So in 2015, I co-founded a mobile health company called Mobicure. So Mobicure is a digital health company, and what we do is we're using mobile technology or digital technology to be able to solve some of our most pressing health issues, especially to advance universal health coverage. So we started by doing a very simple innovation called Omomi. Now, for those that are Nigerians here, Omomi is a Yoruba word that means my child. So we started it as a simple SMS service, which later morphed into a mobile app. So what Omomi does is Omomi targets pregnant women and mothers of under 5s in Nigeria and across Africa. So what Omomi does is that it connects these women to doctors in real time. So these women can actually have a live chat with a doctor from their mobile phones anywhere at any time. And more importantly, Omomi actually provides these women with life-saving maternal and child health information. So they get information on things like breastfeeding, child supplementation, And even from their mobile phones, they can track their children's immunization, and they can even monitor their children's growth right from their mobile phones. In 4 years, Omomi already has over 40,000 women using it in Nigeria and across Africa. So that's one. Another innovation that we launched 8 months ago, which we are really very passionate about, it's something we call My Paddy. Now, this innovation is a sexual and reproductive health app, and it's for young people. So what it offers young people is that it connects young people to health professionals. So also using My Paddy, young people can connect directly with counselors and doctors on any sexual and reproductive health issue. And what makes My Paddy unique is that it's an anonymous platform. We all know what's associated with sex education in Africa. So because it's anonymous, young people can join. They are comfortable to join, and no one will judge you. They are free to access information that is accurate, that is unbiased, that's non-judgmental, and that is youth-friendly. Amazingly, in 8 months, My Paddy already has 11,000 plus users from 19 countries in Africa. So we have users from Nigeria, Ghana, Zambia, Namibia, Kenya, even South Africa. I'll leave you with this, really. What we've done with MobiCure and with our innovations, Omomi and My Paddy, are a clear demonstration of the fact or the role that mobile technology can play in advancing universal health coverage, especially in helping to improve health access and quality of care. And also, I'm a great example of the fact that if you support young people, if you fund young people, if you trust young people can drive innovation. And finally, we can actually make meaningful advancements in universal health coverage across Africa. Thank you very much.
Thank you, Dr. Akime, for showing us what it is that young people can actually do. These TED Talks have been a great way to start the morning because they've inspired us and given us hope. They've not started us with talking about the problem. So we're now going to have a panel, and this panel is going to speak about quality. I'd like us to focus on 2 things as we start the panel. The dictionary definition of quality, and I quote, is the degree of excellence of something. There is no option of not having excellence. And so as this panel talks, I want us all in the room, both the panelists and the audience, to think of 4 Africans, because these are the people who we need to deliver excellence to. A 1.5 kilogram premature neonate in Kumasi called Akwesi. An adolescent in Bambane, Swaziland, who requires specific sexual and reproductive health needs called Ayanda. A hypertensive and pre-diabetic patient in Lubumbashi, Congo called Nyonkuru, and an esophageal cancer patient in Maralal, Samburu called Lechipan. Akwesi, Ayanda, Nyonkuru, and Lechipan. These are the people who we need to deliver excellence to. Not some sort of care, but excellent care too. So with those 4 individuals in mind, for the next half an hour, we have a great panel. So I'd like to invite my top quality panel to join me on the stage as we delve into various issues of quality in universal health coverage. Welcome. Thank you for your time. So I'm going to mention these 4 names again so we can remember who we are speaking about and not an amorphous theory of quality. Akwesi, Ayanda, Nyonkuru, and Lechipan. Those are our 4 protagonists of the morning. So as you give me your responses, please keep them in mind. So on stage to have this discussion with me is Professor Guyer, Professor Gueye is the president of the West African College of Surgeons and a professor of urology in Dakar, Senegal. Welcome. We have with us Dr. Mariam Dahir. Dr. Mariam Dahir is a medical doctor and public health research specialist who worked with the Hagresia group of hospitals and currently works with the WHO to work with HIV/AIDS in Somalia. She's from Somaliland. We have Dr. Ian Askew from the WHO, who works with sexual and reproductive health and research, which we'll be delving into. And previous to that, he was at the Population Council, where he also worked as a director of reproductive health, health services and research in Nairobi, Kenya. Karibu. And lastly, we have, but certainly not least, we have Dr. Fraser Karua, who is the general manager of Amref Enterprises Limited, a subsidiary of Amref Health Africa that runs a portfolio on social enterprises. So she'll be talking to us about that. So we'll start with Professor Gueye. Welcome. Okay. Professor Gueye, welcome.
Thank you.
So my question to you is, 95% of people do not have, in sub-Saharan Africa, do not have access to surgery. And that includes most of us in this room. If we go home to our rural areas and we have an emergency, we will not have access to surgery, me and you included. So keeping that in mind, how can surgery be used as a catalyst to ensure quality across the health system?
Thank you for the question. As you know, surgery is an essential component to universal health coverage because the people mostly die not only because of communicable disease in Africa, but mainly now for non-communicable disease, trauma, and unfortunately, death due to childbirth. And we cannot talk about surgery without quality. Someone used to say that if you think that quality is very expensive, just to try non-quality. You will see that you will invest much more if you opt for non-quality than opting for quality. And the West African College of Surgeons, that I'm privileged to chair now, had its annual meeting in January in Dakar, and the main topic was ensuring universal access to surgical services, meaning that it's not only having the infrastructure in place, nor to have the equipments and sometimes the resources, but everything going around, meaning the way to access the services, the electricity, the running water, all those things that unfortunately in the hospital delay the services to the patient. And that's why we think we have to think global, not only training people, but also having the services around the care. And as regard to the training, we think that as a college, we don't need to wait until we train full surgeons to be sent out to reach out to the population. That's why we have developed programs called mid-level manpower development. So essential surgery is to us very important, and nobody should normally graduate from any medical school in sub-Saharan Africa without having at least some training on emergency obstetric care and essential surgery. And the other thing important is maybe to bring women into surgeries. If you see the demography of women in medicine is increasing. In Senegal, now we're graduating 60 to 65% women in any cohort. But to surgery is still very low. And we have to encourage women to go into surgeries. And hopefully tomorrow is 8th of March, which will be the International Day of Women's Rights, not International Day of Women, because women are the old days, your days. And my hospital tomorrow will innovate. Tomorrow in my hospital, all the surgeries will be performed by women.
Wow.
Tomorrow. I'm the CM of the hospital, and tomorrow the anesthesiologists, the scrub nurses, and all the surgeons in gynecology, urology, neurosurgery, orthopedics, ophthalmology, and general surgery. The OR will be only women OR tomorrow in my hospital in Dakar. Thank you very much.
Congratulations to your hospital. anyone who has any say in an operating room, this is certainly something and a challenge to take up for the next year. I heard from you that women are important to quality, although I may be biased, and that we need to think broad when we think about quality and how we take quality even to the remote areas. Thank you.
Thank you.
Dr. Dahir, you worked in Hagresia, and you had in Somaliland, and you had a lot of experience there. This is a vulnerable situation, a fragile situation in some ways. So keeping that in mind, what are some of the cost-effective changes that could be supported to make significant impact in Somaliland? Please share with us some of your experiences.
Thank you. Good morning. Actually, I don't work with WHO currently, but they are close to my heart. So, for correction. As a young person who came, actually I will give you, before I give you the answer of the cost effectiveness, I will give you an example that happened to me when I was an intern. I was on duty, so I came to a pediatric ward that the nurse was absent. Soon I came, there is two babies came to the ward. One was convulsing, the other one was silent baby. Then after that, the convulsing baby, the family already had some treatment in hand. Because in Somaliland or in Somalia, we have cost-sharing system that we offer the doctor and the bed, but patients who are the one who is paying the service of the medications and as well as the operation. And then the silent baby came from village, as they told me, and doesn't have any treatment with them. So I was focusing the baby who was convulsing, and the nurse came to the ward. After that, I asked the nurse, where is the emergency medication? And she couldn't find it because it was out of stock. And I asked her to run and get some medication from the pharmacy and come to me while I was treating the convulsing baby. When I came to the child who had diarrhea for 5 days in a village, and after that he went to clinic, but they never referred. So as I was handling that patient, he needed interosseous and cannula because he was dehydrated for 5 days with no proper cannula. When I was opening the baby and I uncovered, I have seen mucurated markers that the mom put it because the baby had recurrent diarrhea. After that, I asked it, the baby died in my hand. That was a sad scenario. But in this scenario I'm giving you, it has a different aspect. When we are talking about the quality, it has a different dimensions. There is a lot is contributing to give as a doctor, as a health worker, a quality service. WHO always says accessibility, availability, safety, and all of that, and efficiency. But if we are not training the doctors rightly, if we are not getting accountability, when we are talking about the leadership in health systems blocks and governance, also referral pathway. If you see a baby that you can't handle him, you can't treat him, refer to the health system or the tertiary level, that will help you. So in this area, I had the intern had a limited capacity to do it, as well as the drugs, so the resources of finance, how to finance the health system in that area, how to give emergency medication, as well as the social determinants. People are not coming to the hospital firstly, they go to the traditional practitioners. So, and also the referral and poverty. And so, as I'm concluding this, quality that we are talking, somehow, somewhere, we are putting an ideal way of like vague, sorry to say, but there is a lot that contributing to the quality of healthcare. In terms of when I was involved in a research recently, and we were talking to the women in Somaliland, across Somaliland, and we asked them, and also looked to the registers, 50% of the women that we interviewed developed complications within the hospital. So the hospital that is available but is dangerous. So it is safety as well is another dimension. We always talk about the quality, availability and accessibility, but acceptability as well and efficiency, we always lose it and we can't figure out, because when you don't have a health system that is available, hospitals, health centers, always there is a donors who are pumping money on that, but with no capacity of those who are handling actually, and as well as the resources and emergency kits and all of that is lagging behind the quality that we are talking. If there is no good quality, there is always quality, and we have bad quality. Our system actually is somehow broken somewhere that we are not looking to the efficiency, just we are focusing on availability.
Thank you. What I heard from that I think we all need to remember in the room are two important words: the social context and the acceptability. If the patient cannot accept the care, then it's not quality care because it's not meeting the demand of the patient.
And also the capacity of those who are handling. If we are not handling the like medical education is not strong. We don't know how to do interosseous cannula. The nurse is not can't have that capacity. Even in the referral district level, actually there's also the cost effective that we are talking about.
Yes, so the quality of the education, because it's a continuum of care. If we don't have quality health workers, we cannot give quality care. Yeah. Thank you. Dr. Askew, you currently work in research, and research is key to giving quality. Can you speak to us on research and how it can be used to give the accountability that Dr. Dahira talked about, and how it can also be used to make decisions that ensure quality care?
Well, thank you very much indeed. And I'd like to frame the issue of research much more in terms of learning and evidence and knowledge. And I'm doing it that way because, first of all, we have to focus on what do we mean by quality. And when you introduced the session, you gave us the dictionary definition of quality. But I think if we did a survey in the room, we would probably get 100, maybe 200 different definitions of quality. And this is something which is a challenge for health systems, because quality is both an intrinsic sort of perception of what you think as an individual is good quality care, and then there are operational definitions that the health system has, and these sort of things have to be in place. And this is the health system definition of quality of care. And this is still an area where, if you're not clear in as a health systems manager what quality means, both to the health system and to the women using this health system, then it's going to be a problem to offer the services and then to know and to be held accountable. And so we have to start with a clear definition. And I work for WHO, and we're passionate about universal health coverage. But I do sometimes think we should put the Q in there as well. I think it really should be universal quality health coverage, because sometimes there's a tendency to focus on the coverage rather than the quality. And we have to focus on both. Because if we don't, people will access the services, but if they're not good quality services, as we heard from the Lancet Commission report, people's lives will still be lost even if they're accessing quality, because they're accessing poor quality, which can be fatal in some cases. So to conclude, I just wanted to mention about the issue of defining and measuring quality, because it's something that a researcher can do. I've spent, I don't know, 25 years doing research on quality, and I can give you all sorts of questionnaires and data collection instruments on how to measure quality. But as a researcher, you then end up publishing a paper on quality, and people read about it that way. But that doesn't really help a health system to know whether it's offering quality care and if it's monitoring and can be held accountable. And the big gap we have is succinct, exact, clear measures of quality offered and received. And that's, I think it's because it's such a multi-dimensional concept that it's very hard to translate that into something which a health management information system can regularly use. And it remains a big challenge. There are some examples available, but I think this is really at the crux of the matter when we're talking about research, evidence, and what it means to be held accountable. You have to know what it is you're being accountable for.
Okay, so for the health practitioners or health policymakers in the room, you've given them a challenge. Do you have any suggestions of how they can incorporate measures of quality into the work that they do? Do you have any suggestions?
Oh, yes, I mean, that's the challenge. And at the same time, you know, going back to the women you referenced at the beginning of the session, how can they both influence the quality of care that they receive, and how can their perception of that quality be recorded, and how can it then influence and improve the quality of care that others will receive, assuming that they get the care in the first place. But then can they provide feedback? Can you influence the quality? Can it be recorded? Because if it's just a conversation but if it's on the record that you didn't receive good quality, then it can have an influence, I think.
Okay, so try and find ways to record quality in whatever way that may work for the system or the individual or the patient. Thank you. Dr. Karua, you're working with social enterprises. This is a new concept in health, but one that certainly can be a catalyst for quality. Can you expound on us on how social enterprises can be a catalyst for quality, especially in remote areas?
So social enterprises, in essence, look at the social return on investment, and that's basically the problem that we want to address, and in this case, quality, and definitely also look at the financial return on the investment. And so in their very design, social enterprises must look at scalability and sustainability, and definitely look at measuring how you achieve the social impact that you're investing in. So our experience with running social enterprises has been that in the very design, you have to be innovative in terms of the financing model and the business model, because then with the limited resources, you have to create value and maximize value for Akwesi, Ayanda, Nyonkuru, and Letipan. And so when it comes to quality, the design of the intervention or the product or service that you want to offer at the community level must be designed to actually meet the gaps in that setup, and especially when you look at the rural areas where there's limited access to everything, including technology. It's at the 2G level in most of the African rural areas. So when you talk about Twitter and apps, those don't apply in the rural area. And so designing the intervention to fit the population. And when it comes to technology, for example, that has been shown to achieve scale and increase access to information, service, and to educate the communities, then we look at the design of the product and service to be able to be applicable to that population. And therefore, the perception then about your products within the community must be about value, must create trust, and must link them to the formal health sector that, as we've seen earlier today, is structured to address gaps in health. And so social entrepreneurship really is about looking at both the social impact and the financial aspects of the solution, so that it's sustainable over time and it's scalable, and therefore it becomes cheaper as you have more people access, because then it's creating efficiencies and definitely increasing information to the user that it's supposed to serve.
Thank you. So I hear scale, because scale equals efficiency, and that also equals affordability. I hear value, trust, and designing the intervention for the community. So as we think about social enterprises, and we've had an example of some today, those are some of the things that we should think about, because that helps give us quality. Thank you to my panel for answering my questions, but we also have many people in the room who I'm sure have questions that we'd like to speak about quality directed towards the panel. So we'll take this time to take questions from the audience. Please keep your questions short, and please make sure your questions are questions and not interventions. We'll take one from Dr. Girenji.
Well, thank you very much, the panelists and the moderator. Very quick question, because this is the Africa Health Agenda International Conference. If you look at the African context, and if you look at the moderator's initial definition of quality as excellence, which excellence means the top. And when we look at the situations you're working in, and Professor Gueye, you'll be witness to this, there are places where surgery is required, okay? And that surgery is required where there is also supposed to be somebody who can provide adequate anesthesia, and yet you don't have an anesthesiologist as you have in the places where in Europe and North America. So in terms of the context we work in, is quality adequacy to provide desired outcome, or is quality excellence? And I think I would like somebody in the panel to speak to that, because we have the danger of presenting to the government here the fact that quality is equivalence, where you must do what Europe and, and America is doing in terms of quality. Therefore, they go back and they buy more expensive, what's seen as excellent equipment, instead of providing adequacy of outcome, desired outcome. So maybe a quick comment on that would be helpful.
Maybe we'll take another question before we go to the panel. I'll take the lady with at the back. Oh, someone has a mic. Sorry, you can go ahead, sir.
I'd be interested. I was very struck by Dr. Karua's presentation, and I wonder if you would like to comment on this. My experience in the health sector, which is not a lot, is that people in the health sector tend to operate on the basis of what they think people need, rather than on what they know people want.
One more question, and then we'll go back to the panel. We'll have a lady for gender balance.
Good morning. I'm Marian Suba. I work for Chipago in Liberia. And as we know, Chipago, their key mark is quality and getting the services out to the people. From the panel, my understanding, we're looking at that access is very important. We need to get to the people out there. And we don't have the kind of technology of Twitter and all of those things that people have around that we can do that social mobilization and get. And I'm thinking, okay, the community health workers are those people. So why don't we focus more on how can we get those community health workers in the community, being the technology, the innovation that we focus on, instead of looking at all of the different things that we look at that we think community health workers should be doing. Why don't we use them as in the community, focusing on what can happen in the community, how we can even go deeper with them as supervisors, as researchers in the community. I see people always trying to take them from in the community and say, okay, we want for them to advance, and they can even become doctors. Why don't we continue to work with them in the community, going deeper and doing more in their community, since they are, as we say, the ones that can get out there? Thank you.
Thank you. So we'll take that round of questions. The first one was about quality. Before we came into the room, the panelists and I had a discussion on how do you say quality in different African languages. And we couldn't figure out how to say quality in Kiswahili, and we had to Google. So quality is a very amorphous thing. And it's something that if we can't find the word in Kiswahili, how do we find the right definition in health? So I'll give that to Dr. Askew to try and respond to Dr. Girenji. Is it adequacy of care or is it excellence? How do you respond to that?
It's a great question, Dr. Thinji, and thanks for asking it, because I think it's at the heart of what we're talking about today. And it raises the issue about standards. And do you start at adequacy as the lowest level of quality and excellence is the highest level? And then as a provider, where do you get? I mean, you cannot sink below the lowest adequacy, and you should strive for excellence. But where you fit in that gap will depend on resources available and the passion and the drive of the health system to reach the excellency level. As a quick anecdote, one time I was working in Ghana, and the Ghana Health Service asked us to help them to develop standards of quality of care for their reproductive health program. And we were about halfway through the process, and they started to think about, well, hold on a minute, if our providers don't meet that standard, does that mean we have to sack them? Or what do we do if we don't reach that standard? And it's a major dilemma, but it's something I think which needs a lot more attention, because it will drive the quality that is received by the clients. If standards are considered from the beginning and minimums are held and maximums are sought after, I would like to put it that way perhaps.
Thank you. I see a nod from Dr. Gedenji. I think that means he agrees with us. The next question was, how do we define care? Is it what the health system thinks people need, or is it what people want? Professor Gueye, what is your response?
It can be what is people want, but it can be what is feasible too and doable. And I feel that we should link it to the expectation of the population. But overall, we have to take care of whatever we do, quality should be there. And in me, it includes the social responsibility of the training institution to make sure that whatever we provide to the society should be in quality, enough quality to be safe. Because when we talk about quality in surgery, it is still safe surgery. And if you manage to have national surgical obstetric and anesthesia plans for every single country, and we have to implement at any level, I think we will be able to maybe cover the essential needs for the populations, but just adapt it to what we can do. But you allowed me, before I just finish, to pay a tribute to a country and to people. When I started surgery 36 years ago in Senegal, my first surgical mentors was from Rwanda. And there were 3 of them, very beautiful, handsome men. One was Emmanuel Kagambirwa, who is surgeon here. One was Emmanuel Kayibanda, who is surgeon here. And one is in the room. And I want to recognize Eugene. Eugene, can you stand up for people to see you? This is the first man. These are the first people who taught me surgery, and now I'm a professor and have to pay tribute to them. Thank you, and please tell to all of them how I love them. And the second tribute is to a country called Rwanda. I can't say privileged. I was in this country 25 years ago as a young consultant, as a surgeon during the genocide. And I spent 9 months in Rwanda doing surgeries. And 25 years ago, I see the difference between where Rwanda was and when I was young surgeon from 94 to 95 in Rwanda, and where this country is now 25 years ago. And this is quality. And I have to congratulate the Rwandese people to have gone this way to bring quality. Thank you very much.
Thank you very much. And thank you for your tribute to Rwanda and for your mentors from Rwanda. It shows the great work Pan-Africanism can do if we share with each other, because Rwanda produced Senegal, who will produce other countries, who will produce other surgeons for the region. Unfortunately, we've run out of time, and I do know there's a question we didn't answer. I will task Dr. Karua with meeting the participant and trying to respond to that so that that question isn't answered. So thank you for your time. We've spoken about quality. I'll remind you of the 4 people who were keeping in mind as we spoke about quality. Akwesi from Kumasi, Ayanda from Babane, Nyonkuru from Lubumbashi, and Lechipan from Maralal Samburu. Remember, these are the people we need to give quality care. And so as you go back home, and as you try and grapple and understand quality, try and remember some of the things that the panelists have said. It needs to work for the people, there needs to be value, there needs to be trust, there needs to be systems, and it needs to work for those who we are giving quality care to. So I hope we've given you tools, words, frameworks that can allow you to have quality as you go back home and think about UHC. Thank you to the panelists. We've spoken about quality. We're going to switch over to innovation as a way of producing quality. To lead this next session is Dr. Priya from the India Public Health. Thank you and welcome.
Good morning, everyone. It's been a long first session, and I have the unenviable task of having some very exciting panelists, but very little time. So I'll do my best. So we move from quality to innovation, a theme that's kind of resonated throughout the last 2 days of this conference. Just to set the tone, healthcare innovations generally occur across a spectrum. They range from small changes that improve some aspect of healthcare to major shifts that have sweeping effects on the entire health industry. So the global commitment to universal health coverage sets out a very ambitious agenda for equitable, affordable access to good quality healthcare. However, the path to UHC is often dictated by demography, epidemiology, governance, and economic constraints. So while limitations in the public sector have created health systems gaps, many countries in the global south and NMIC settings are turning to innovative actors who are often disrupting traditional health markets to supplement healthcare provision, access, and affordability gaps. So this session will really explore how innovative technology and new models of healthcare are able to bring complex and expensive healthcare services and products to greater levels of affordability and accessibility, especially among vulnerable populations who need them the most. So without much ado, I'm going to introduce a really exciting panel, and I'm going to call them on stage. I'd like to call to the stage first Ms. Claire Morris, our first speaker. She is the International Programs Director of Babylon Health, a smartphone app powered by artificial intelligence. Babylon Health embodies the mission of universal health coverage, according to them, we'll see more, with a goal to provide accessible and affordable health services to everyone. Welcome, Claire. Next on the stage is Benjamin Norty, and in Zambia, by applying the techniques used by producers of fast-moving consumer goods and the distribution of health products. Mr. Berry is an innovator, designer, and social entrepreneur who's also working to influence essential medicine distribution across sub-Saharan Africa. Welcome, Simon. And we have Israel Bimp next, the head of national implementation in Rwanda at Zipline International, a company that's redefining the way health services are transported and health products are transported, a company that designs, builds, and operates small drones to deliver essential medical products in Rwanda and Ghana. And through this model, Zipline provides close to 11 million people with instant access to urgent medicines. And last, but most certainly not the least, Dr. David Fleming. He's PARTH's Vice President of Global Health Programs, which brings together PARTH's significant country experience and technical expertise to facilitate the organization's ability to achieve impact through innovative approaches and solutions. He's going to be talking to us a little bit about process innovations and how that's really making a difference among country health systems. So the format of this session is 5-minute presentation by each of these exciting folks, and then I'll throw a couple of questions at them, And if we still have time, I'll open it out to the audience, but if I don't, forgive me, you can accost them at the end of the session, all right? Okay, here we go. So Claire the first presenter will be Claire.
Hi, good morning, and thanks very much. And it's a great honour for me to be here and to present Babylon Health. We are a UK-based digital health company. You can see our very bold mission here, which I know will resonate with every single person in this room. We look to find ways to use technology to address the challenge that we're all aware of, that 50% of the world's population doesn't have access to health services. So what can we do using mobile phones and using modern technology to really address some of the challenges, the challenge of lack of human resources in the area of health, of the cost of health, and of the timing of health, which particularly in this part of the world everyone is very conscious of. If you will forgive me for one minute, I'm just going to give you a little bit of a flavour of what we do in the UK, which is where we were established in 2014. In the UK, you can use our AI-enabled smartphone app to give you information and advice about your health service. You can then access our virtual services. So we've got GPs, general practitioners in the UK that you can have a consultation with anywhere you are at a time that's convenient to you. And that can be done by audio or video. And we also have a few physical clinics, and the reason that we have that is because we have a contract with the National Health Service, and for the 20 to 25% of consultations that cannot be addressed by video, by phone, we have some physical clinics. You will be not surprised to hear at the end of this conference that the first country we came to in Africa on invitation of the government, a government that believes in embracing innovation, was Rwanda. And we set up in Rwanda in 2016 with support from a range of stakeholders, both across the government and within the private sector, to enable us to set up an adapted service, an adaptation of what we have in the UK, which is on feature phones. And what we've done is created a primary healthcare service via feature phone, a quality primary healthcare service, that anybody can access. So the way it works is that you have to register with us, and for any Rwandans in the audience who are not members of Babel, please do join us. It's *811#. And you can then, what happens is you register with us, and then you get, if you're feeling unwell, you can book an appointment through the USSD platform, and you get a call back from a nurse, and a nurse will go through a triage with you to discuss your immediate needs, whether there's information advice she can provide, whether you need to be referred already to go to your health centre, or whether you can have a consultation with us. If you need a consultation with us and we can provide that, we can then give you a call back with a doctor or with a nurse to provide a consultation. We are now integrated with through the Ministry of Health. We have a license with the Ministry of Health, and we work very closely with the Rwandan Social Security Board, which enables us to offer our patients e-prescriptions and lab prescriptions, and obviously referrals into the national health system. What has enabled us to move very fast in Rwanda is this incredible climate for innovation, a very, very dynamic team, great stakeholder relationships and support from the Bill and Melinda Gates Foundation. And within a very short period of time, we have registered over 2 million Rwandans, and we have provided 350,000 consultations. And the team here in Kigali, so as we're here right now, they're a team of nurses and doctors providing consultations, and they're doing between 2,000 to 2,500 a day. And we have integrated, as you can see, across Rwanda with health centres and pharmacies. What has been really important for us is to understand who we're actually reaching, and we did an independent research at the end of last year to look at equity, and we found that we are reaching across the Rwandan population, both in terms of geography, in terms of socioeconomic groups, in terms of gender, and in terms of age. Quality is also very important to us, and there's a couple of aspects here. Interestingly, following on from the last session, clinical governance is in fact facilitated by technology. So if you imagine every single one of our consultations is recorded, which means at the end of each month our chief medical officer can then review a sample of those consultations and really understand, have the clinicians follow the protocol, have what was their interaction and style and care with their patients, and was there resolution. So it gives a great insight into the actual service that a patient receives. And our clients that we give sort of client satisfaction surveys as well as look at it through research are very satisfied with the service. And just to sort of follow on, we are a very ambitious company. And we have some pretty ambitious expansion plans. We are already working in a number of countries and expanding into others, but very much hope to be able to make further contributions to other countries here in Africa in terms of advancing UHC, complementing and supporting both public and private health systems. Thank you.
Thanks, Claire. We next have Benjamin Norty from Mint, who will be talking a little bit about his innovation.
All right, thank you very much. So Mint Innovations specializes in robotics and AI. So over the years, we have tried to look at how robotics technology can actually, facilitate healthcare delivery. So one area that we have actually taken great interest in terms of health is in the area of autism. Now, autism is one subject area that, in many African countries, particularly Ghana, in my country, much attention has not been given to it. And generally, people who have this condition are even considered as having some spiritual affiliation, and I mean, generally they are even not treated well. People don't tend to give them the needed attention that is required. So the innovation that we have been working on really is trying to figure out how this technology can assist these children, mainly children. So we have actually taken the pain to visit a number of autism centers in Accra. And the interesting thing is that because there's not much interest, sometimes, finding the people, who have that challenge and, trying to address that need is always very difficult. And it is also interesting to know that this particular disorder among children, the treatment procedures can be quite expensive. So typically in some of the autism care centers, you'll be spending about $200 every month, when you send your child to these centers to be given the proper care. And, for even many middle-income earners, they can't afford this. And people in remote communities also don't have the care. So, I mean, it's quite weird to think about how robots can actually think about this, because a lot of time when you hear the term robots in our African context, what people tend to associate it with is like weaponry. So, I mean, there was a time we were traveling from one place to the other, and we got to the police barracks, and they had to detain us for hours because when they saw the robot, they insisted we're carrying weapons of mass destruction. And that was quite unfortunate. So what we are currently doing is using these robots to aid children who have autism. So if you know anything about autism, it's a mental or neurological disorder that actually occur in children, mostly like under 3 years. And it's something that normally stays with them. And, you know, if you live in a country where there are no like proper infrastructure or mechanisms to actually help you, then you're going to be in very serious trouble. So what we have taken upon ourselves to do is to work on this autism assistive technology care robot. And so what we are doing is offering therapy. So we want it to become like a tool for therapy. And so, you know, we don't necessarily intend to use these devices to like replace human beings, because that was, you know, some of the things that people were raising, other ethical issues. So what we've been trying to do is to pretty much understand, you know, how these children actually, you know, function, some of the defects that they have, and trying to actually model that and use these robots to, you know, enable them to, you know, perform certain key activity. So currently we're still, you know, doing testing with a lot of centers. So we want to be able to like shape this technology to meet the appropriate needs of the individuals who have these conditions. And what we're also looking at is designing this generic device, which is this robot that can actually be fine-tuned, you know, in the whole of Africa. And it's actually interesting to note that, in fact, we started this as a research program. In fact, I've been working with PhD students at Kwame Nkrumah University of Science and Technology, and we are, you know, hoping to actually bring this technology to light. And one of the things we also discovered was that really, you know, within the African community, we haven't had a lot of research going for this thing. So I believe strongly that as we look at universal health coverage, you know, these technologies are available to us. In fact, we live in very exciting times where tools and technologies are available at our disposal. And instead of using them for like weapons of mass destruction, we can actually use these robots to help you know, people, especially children who live with autism.
Great. Thank you so much, Benjamin. So we move on from robots to simpler forms of innovation, but nonetheless equally effective. So over to you, Simon.
My name's Simon Berry, and I'm the co-founder of Cola Life. Cola Life gets its name from the uncomfortable question, how is it you can get a Coca-Cola wherever you go in the world, but you can't get life-saving medicines? The problem that we're trying to address is that diarrhea is the second biggest infectious killer of children, second only to pneumonia, and it kills more children than all the other infectious diseases put together. But we know how to treat diarrhea. There's been a recommendation in place for 15 years, and the treatment is oral rehydration salts and zinc. The problem is that less than 10% of children or cases receive that treatment. So we studied the way that Coca-Cola gets its products everywhere, and we applied those principles to a health product, a diarrhea treatment kit. The way the Coca-Cola system works, in a sentence, is that they design an aspirational product. They then market that product very intensely to the people they want to buy it. And then finally, they put the product into the distribution system at a price that enables everybody along that distribution chain to make a profit and for the product to be affordable to the majority of people when it gets to them. So we did exactly the same with, but with a health product. Given that the product design is absolutely crucial, we had the task of designing an aspirational diarrhea treatment kit. So we had to start by asking our customers what they wanted. And this is what we came up with. We asked them what features they wanted the kit to have, what they wanted it to look like, how they wanted it to be branded. And there are two formats, there's this one and this one. I'm going to demonstrate how this one works. It comes in a container which can act as a measure for the water you need to mix the ORS and zinc. Inside, I don't know if the camera can focus on this and get up onto the screen, we have zinc tablets, which is one element of the WHO recommendation. We then have oral rehydration salts, 200 milliliter oral rehydration salts, because our customers told us that liter sachets were too big. And we've also, in this format, included soap so that people could be reminded of the hygiene aspects of prevention of diarrhea and could prepare the treatment in a hygienic way. So you take out the contents, you fill it up to the mark. Again, if the camera can focus on this, it would be helpful. There's a little 200 millimeter mark on there. You take one of these sachets, you open it up, and you pour it in. Now, at this point, if you have a sick child, that sick child somehow is not quite so sick because they get very excited when the liquid turns orange. You then put the top on, no flies, no dirt. You shake it up, and there you have 200 mils of perfectly mixed ORS in a hygienic form, and the child can drink it as and when it needs to. So cheers. We have now left Zambia. Cola Life has left Zambia, and we have left both of these formats on all the supermarket shelves nationwide. We started off with 1% of children receiving ORS and zinc as a treatment. It's now more like 43%. In health centres, right up to about 87%. What has really improved the coverage is that the government, who we've been working with from the outset, have got behind the product, and the same manufacturer within Zambia now produces a government version which goes out to health centres and is given away free. So we have a commercial product that sits alongside a free product, so both channels are available and accessible to caregivers. Thank you very much.
Thank you, Simon. That was really very interesting. We next go on to Israel Bempe. He's part of Zipline, and he'll talk a little bit about drones.
Thank you so much. I wish I could demonstrate it from here. However, what we found as an issue when we started working in Rwanda is the government wants to put every citizen of the 12 million within access of a health product within 30 minutes. And they've done a lot in that process by building health centers, hospitals. Every district has its hospitals, some have two, and every sector has a health center, and they're now building health posts. But that comes with the challenge of accessing medical products. And as these health facilities increase the package of services that they provide, that means they have products, they need to have more products and more machineries to be able to store them and so on. But that is a challenge in the supply chain in general. And that's how we partnered with the government of Rwanda in 2016. It's not working. Oh, yeah. We partnered with the government of Rwanda in 2016 to be able to build our first distribution center in southwestern Rwanda, which was supposed to serve the first 21 hospitals in that area of the country. Within a radius of about 80 kilometers, and we've for that part, that's what we've been doing, and we started with blood. And why we started with blood is that, it's one of, as the package of health services increase at district level of hospitals and some health centers get to increase what they provide as a service, there is a need for critical blood products. And some blood products have a shelf life of 1 day or 7 days, and that's very hard to store. What they would do before is they would overstock themselves, or they would have to transfer a patient whenever that product is needed. And that's not good for the service levels that health facility has to provide, and it's demoralizing for health professionals who think they are at a health facility but have not all the right tools to provide the care that they need to provide. I'll explain briefly how it works. So we receive an order using a web portal, mobile phone, and then we package the blood products that we receive into an insulating package, and that protects it against fragility. Then our flight operator takes the package, loads it into a drone, put it on a catapult that will launch it from 0 to 100 kilometers within half a second. And then it goes away from our distribution center to the health facility, flies at 100 kilometers per hour. And before it reaches the health facility, we will notify the hospital that it's 5 minutes away or a few minutes away. When it reaches the health facility, it drops a package at a height of 10 meters. The package has a parachute, so it lands gently, and the laboratory technician can take the blood. And while it takes the blood, the drone is on its way back. So they don't need to put any machinery there. And because it's an amazing technology, I'll just also show you how it lands back on our distribution center, although it's not very relevant for the conversation. Hope it works out. It's a heavy slide with a bunch of videos. However, when it comes back to our health distribution center, what we did, we designed a recovery system, and the recovery system helps it to pretty much catch the drone and communicate with the drone every second and so. Okay, I hope it works. If it doesn't work, we'll go ahead and I'll invite you to visit us tomorrow. So what happens is, now in 2019, what we did, we opened the second distribution center in eastern Rwanda. And we now put almost every citizen within range of our services. And now we are expanding also not only from blood, but we are also starting to deliver medical products and vaccines. And with that, we will be able to reduce at the same time stockouts, but also waste that happens, because in addition to the normal supply that happens almost every month or so, we will be able to give to the facilities what they need to replenish their stock before the routine supplies happen. And that's probably a discussion we'll have later, how we work to integrate into the existing supply chain instead of being a silo aside. Thank you so much, and I look forward to see you all tomorrow.
Thank you, Israel. We now move on to Dr. David Fleming, who will talk a little bit about digital innovations and how they're changing the way governments are orienting themselves around health systems.
And as a spoiler, there are no cool videos in my presentation. Good morning, everybody. It's really a delight to be here, and I'm honored to be part of this conference and part of this panel today. I would like to take just a few minutes of your time to talk about the use of frugal innovation to advance primary health care. And in particular, I'd like to use the example of health registries and the power of digital tools to transform these registries and make them a vital part of primary health care. You know, let's see if I can get the slide to advance. There we go. My bottom line is that digital approaches to enhance frugal innovation are probably some of the most powerful tools that we have to advance health equity. As one example, we all know globally, 1 in 5 children don't get the immunizations that they need. In order to achieve universal health coverage, we're going to need to solve that problem. In order to solve that problem, we need the data, and we need to use that data to figure out how to reach those children. I thought I'd personalize this a bit by introducing you to Beatrice. She's an amazing primary health care nurse in Tanzania who has the job of running immunization clinics there. And that is an incredibly tough job, as you all know. In the past, she didn't know on a given day which children were due for vaccines, how many would be coming in, whether the vaccine stocks that she had would be sufficient to meet the demands of that day. She had to force her way through paper records, tally numbers manually, and report centrally using old-fashioned paper forms. Working with the governments of Tanzania and Zambia, PATH and its partners have tried to change that. And in particular, we've introduced the concept of an electronic immunization registry. An electronic immunization registry is nothing more than a patient-level digital system that tracks each child's vaccination and the schedule and the doses that that child has received. It's simple to operate. Frontline workers like Beatrice use tabloids, mobile tablets, and then those data are aggregated centrally for use locally, regionally, and by the National Ministry of Health. And in this way, you actually get the information that you need in order to provide immunizations. And in particular, having this patient-level data available to you allows that frontline health worker to optimize delivery of services. It allows them to know not only what's happening to that child that day, but what's happening to that child across the entire healthcare system, for example, in their well-child visits. And it allows smart decision-making by having the data available in front of you and by having the decision support mechanisms embedded in the software to provide the services that are needed. And even better yet, if I can get it to advance, it works, unlike these slides. There are now over 500,000 children that have been enrolled in these registries in Tanzania and in Zambia. And one of the first results, remarkably, is that Beatrice now needs 41% less of her day to provide the job of registering and vaccinating children. It's frugal innovation. It enables that to happen rapidly. And in addition, she spends 8 fewer days a year manually reporting information centrally because the system does that automatically. And more importantly, these data are now being used to actually improve the quality of care that we just heard about at the level of service delivery to identify those children who are not coming in, sending them reminders, or better yet, sending a community health worker out to bring them in. At the level of the facility to understand better the workforce needs on a day-to-day basis and to assure that the vaccine stocks that are available are actually sufficient to meet the demand that day. And then at the policy level, centrally, to give policymakers the opportunity to see system-wide what that picture of immunization looks like, where that missing 20% of children are, and to allocate resources effectively. And so we're running short on time, so I'm going to stop, but the story doesn't stop here. This notion of frugal innovation, of which immunization registries is only one example, is really the key in my mind and PATH's mind and in many of our partners' mind to moving forward to universal health care in 2030. So this is the beginning of the story. We can do the same thing across the range of services that are needed to achieve this goal. So thank you very much.
Thank you so much. So in the interest of time, I'll begin my first question, and if I could just request you all to kind of keep your answers brief so that we have some more time to kind of interact with the audience if possible. I mean, what a range. Artificial intelligence and chatbots, robotics, supply chain innovation and delivery, the use of drones in the delivery of blood products and medicines, and using digitization to make health systems far more manageable and affordable. What an incredible range of innovative reform. So my first question to you is really, as countries move towards universal health coverage, and all of you all have such diverse and interesting models of innovation, how do you see yourselves embedded and integrated in country health systems? How do your business models, if any, adapt themselves to integrating with country health systems for the long haul, which is what universal healthcare is all about? So a couple of comments down the line. let's start from you, Claire. I'm just going to go through the panel, so yeah.
Sure. Thank you. And I think, I think that the key to sort of sustainability, but more important to having impact, is being embedded and working at a national level. I think we've been very lucky here to work with the Ministry of Health and the Social Security Board that sees the value of expanding the range of actors under supervision and under their guidance within the health system. So I think we see that as a huge opportunity. We also, through our technology, have the opportunity. We work not just here, but there are other governments that we're working with who actually we can license our platform to, so that they can offer the same type of service but run by themselves. So we're open to we want to make our technology available, and we'll then be adapting to different markets and to different health systems so that you can fit in with the existing infrastructure and the existing policies of different countries.
Great. Benjamin.
So, finding this technology in various places is one key thing, and for us, one of the key things that we're looking at is how we'll be able to reach out to people, especially within the remote communities, to try this technology, and also we're looking at working with key stakeholders, the ministries. Currently, we don't really seem to have a very good framework when it comes to issue of autism, but through consultations with ministries and just having several discussions, we believe that this technology can go a long way to save lives and improve the health of children with autism.
Great. Thank you. Simon.
At Cola Life, we have one very simple rule, and that is we do not do anything that makes us a permanent part of the solution. Cola Life are two people. We do everything through existing systems. We work within the existing policy of government. We work within the existing regulatory framework. We do no regulation. We do no policy development. We work through local manufacturers who make the product. We work through local distributors who distribute the product. And that means we can do what we've just done, and that is remove ourselves from Zambia, and the development, the development that has taken place there is self-sustaining. Our strategy for impact is to grow our impact, but not by growing Cola Life. All of our knowledge, our expertise, our evidence is available to anybody, anywhere, who wants to pick it up and use it. And we will help anyone who wishes to do that. We are currently helping a small team in Nigeria, for example, who are looking at what has been achieved by Zambians in Zambia and looking at how they can adopt and adapt it to the Nigerian situation.
Great, thank you. Israel.
We also get embedded into the health system, into the supply system for blood delivery through the National Center for Blood Transfusion and through the Rwanda Biomedical Center for Medical Products and Vaccines. And, we make sure to integrate ourselves into their data system. So for blood, we use the National Hemovigilance System or whatever electronic management information system that is used for medical products. That's to provide the same amount of visibility that they would always have in the channel. And also, we build flexibility into what we can deliver, where we can deliver, and how we can deliver it, so that we don't become a burden for the health supply chain, but so for example, we don't have a fixed list of products. Instead, it's flexible depending on the demand and the needs of what's happening at the clinics and health facilities that we serve. And we also make sure to collect as much data as possible to provide visibility over time into how our service is either increasing demand, and that how could inform certain decision making that happens in what needs to be done. And one more thing that I would say is, because we provide a whole package, it's not only about drones, but it's also about the health aspect and the distribution aspect as well, where each of our distribution center has a warehouse, a pharmacy, what we call a fulfillment operations area that allow us to have the understanding of what are the needs and how we can solve that. And we also use it to inform our stakeholders to understand what is it that's happening depending on a just-in-time service, and they can be able to respond it from a policy perspective and how they plan for the future.
Great. And this is, in essence, it's an easy question. It's an easy question for us because we actually start with the Ministry of Health and with the system and ask, what is it that you are trying to do to advance primary health care? Are you trying to shift tasks to the front line? Are you trying to improve self-care abilities of the community? Are you trying to do social mobilization? Whatever it is that are the priorities to advance universal health care, it turns out that there are digital approaches to make that simpler, easier, and more efficient for you to do. Let us talk to you about that. We're product agnostic. We don't come in with software. We instead are sort of provide the technical advice to say, given what you're trying to do, what are the range of digital options that are available to you to get that done more efficiently and effectively?
Great, thanks. So I have one more follow-up question. And innovators are ambitious, and great ideas are often thought in terms of translational terms. The world is also a smaller place, and people are constantly looking at borrowing and trying out innovations across regions and borders. So my second question is around scale. So taking innovations like yours to scale often involves multiple actors, multiple agencies and partnerships. So in your experience as technology operators who are disrupting existing markets, as innovators who are working within existing health systems, what are some of the factors that have either facilitated or do you think might impede scale? And second question is, as you look to advance beyond geographies and improve your market share across countries, how would you navigate some of the regulatory and legal challenges around the disrupting stuff that you're doing? I mean, drones, for example, do you impede aviation space, robotics? Where's the question? You know, how does one interface with human factor? Chatbots, in your case, you know, how do you account for, are there accountability mechanisms that you put into place? So how does scale react with all these things? A couple of points from all of you.
I'm happy to start. I think to start with what impedes scale is, my responsibility here is to integrate Zipline into the national health system, the aviation system, and the technology ecosystem. You know, what healthcare professionals see as a need is not what the aviation system see as feasible. So for example, there are a bunch of no-fly zones in the country, while those no-fly zones have hospitals and health facilities that need our services and so on. But one thing that we think we've done, especially on the business side of things, is changing how we think about this. And that allows us, before when we started, it was a service where you pay per delivery. But we realized that that also affects how people want to use this service. A health professional was afraid to request one bag of platelets or 2 or 3 because they think it doesn't make sense for only one delivery. But then we moved it into a more of a subscription model where they now have the flexibility to use our service for a certain amount of flights over a certain period, and that allows us to really scale. And on the technology side of things is to be able to sell the service yourself, but because Zipline designs, manufacture, and do the operations. So in that way, we collect a lot of information and we know exactly where we need to improve by how we do things. And to address the elephant in the room is when it comes to cost. For example, what we did is, we are backed by some of the best investors in the world who make sure we develop and sustain our products. Then the governments and different other clients will pay only for the operations and service that we provide to them, while other global health partners would come and support certain aspects like setting up in a new country or setting up a new distribution center. We believe fluidity in that kind of work allows us to be able to scale our service and replicate it in many different markets and aspects.
Great. Any more comments from anyone else?
Could I just make a comment about the way we're working? Innovation, by definition, is new, and the challenge is to move it out of its sort of newness into the mainstream. And that often requires changes in regulations, changes in policy, and so on. And we quickly realized that the move of the activity from Zambia to other countries was going to require some policy change. So we, as well as supporting other countries who are approaching us and doing that in a passive way, we have worked with PATH, with the Diarrhea Innovations Group, to submit an application to WHO to get co-packaged ORS and zinc on the essential medicines list. A decision will be made about that in April, and the result will be published in June or July. So we hope that in June or July, co-packaged ORS and zinc will be on the WHO essential medicines list. We will then work to cascade that down more quickly than it would cascade otherwise to national essential medicines lists. So then our experience in Zambia becomes a way to implement policy rather than yet another innovative activity in other countries. So we sort of switch from the doing and the demonstration and the generation of evidence to the policy space, so that what we're doing is no longer seen as an innovation, but seen as a way of delivering the current global policy.
Great, thanks. Thank you, Simon. I'm afraid we're out of time, but the organizers have allowed one question, and that lottery goes to Dr. Githinji.
It's actually not a question, it's an apology to the audience for having such a male-dominated panel. I promise you we're trying. We are conscious that we need to have balanced panels, and please accept our apology. You agree that the speakers were excellent, so they were not chosen because they were male. They were chosen because they have something to contribute, and we will make up for this because we have an excellent all-women panel today in the afternoon, which is the best thing to do on the eve of the International Women's Day. Thank you very much. That was all.
Thank you, Dr. Githinji. I will save my summary because I think we're really out of time. Claire Morris, Benjamin Norty, Simon Berry, Israel Bempi, and Dr. David Fleming, you have told us that innovations are alive, well, and kicking, and really represent the future of health systems, not only in Africa, but most likely in Asia in the very near future. Thank you very much.
Thank you.
Another round of applause for our panelists and moderators for the session. So this concludes our morning session. We are now going for a short break. I think Desta has an announcement.
Good morning, all. We had a fantastic session. Thank you so much for getting up very early. This was our last morning session. And I just wanted to take this opportunity to say, after an amazing 3 days of great interactions, partner-led sessions, we want to invite you to a cocktail reception immediately following the plenary 7, which is the all-women plenary. So please put it on your calendar, cocktail party, to close the session. Thank you so much.